Hello, my dear students. Today we are starting the discussion about inflammation. Inflammation and repair. This is a set of lectures which we'll discuss in next 3-4 lectures in a row. So what's the inflammation? What's the definition of inflammation? The first. So I want to concentrate your attention on this definition. Inflammation is the response of vascularized tissues to infections and tissue damage that brings cells and molecules of host defense from the circulation to the sites where they are needed to eliminate the offending agents. Let's divide it. First of all, of vascularized tissues. Which vascularized tissues do you know? First of all, vascularized tissue is our connective tissues. You remember we have loose connective tissues in our body, yeah, first of all, these tissues get inflamed. So we need connective tissue with a lot of blood vessels, capillaries, and arterioles. So and the site of inflammation is first of all related to these vascularized tissues. Okay, what causes it? Infections and tissue damage. So as we discussed earlier, so every tissue damage, so causing the effect of inflammation there. I remind you that in the cell we have inner cell membrane, so revealing of which causes the activation of macrophages, and so after the macrophages starts the rest of inflammation. About details of this we'll discuss during this lecture. Then infections. So infections, we have different types of infections: viral infection, fungal infection, and more commonly it's microbiological infection. Inflammation, main fate of inflammation is the bringing of cells and molecules of host defense from the circulation to the sites where they are needed to eliminate the offending agent. Once again, what is offending agent? Offending agent might be bacteria, virus, might be fungi or protozoa, so a lot of different acquired reasons, but also our tissue damage. So even in cases of other types of injuries, we have offending agent in a way of damaged cells. So it doesn't matter. It might be damaged by heat, damaged by frozen, damaged by ultraviolet, damaged by radiation, damaged by autoimmune cases. So any of this damage can cause the inflammation reaction. And we'll discuss it in previous lectures. Little bit we discussed, but today we'll discuss all the mechanism of this process. So, and also I want to mention that we used to think that inflammation is something bad. Yeah, it's that we treat inflammation of different organs. We try to cure it with different medication. But don't forget that inflammation is normal reaction of human body. It's normal reaction to offending agents. And in 99% of inflammation cases, it leads to healing, and we don't mention, when our inflammation so healed us, but sometimes this inflammation goes very acute way, and we have to treat it with the help of drugs. So and the inflammation serves to rid the host of both the initial cause of a cell injury. It might be microbes, toxins, might be consequences of such injury like necrotic cells and tissues. That's the main task of inflammation, to relieve these causes. Okay, mediators of defense include phagocytic leukocytes, antibodies, and complement proteins. What are they? We'll discuss furtherly in these three lectures. Most of these normally circulate in the blood, where they can sequestrated so they can damage normal tissues, but can be rapidly recruited to any site in the body. And mechanism of this also will be discussed soon. So it's like preview, yeah. Some of the cells involved in inflammatory responses also reside in tissues where they function as sentinels on the lookout for threats. The process of inflammation delivers leukocytes and proteins to foreign invaders such as microbes and to damage or necrotic tissues, and it activates the recruited cells and molecules which then function to eliminate the harmful or unwanted substances. With inflammation, infections would go unchecked, wound would never heal, and injured tissues might remain permanent festering sores. Um, so, what is the source? We'll also discuss it. What is it? The typical inflammatory reaction develops through a series of sequential steps. First step is offending agent, which is located in extravascular tissues, is recognized by host cells and molecules. That's normal reactivity of the body. Then second, leukocytes and plasma proteins are recruited from the circulation to the site where the offending agent is located. So we just so our blood our body identifies it and reads the site of this. So what can eliminate this offending agent? Then leukocytes and proteins are activated and work together to destroy and eliminate the offending substance. So actually activity of these leukocytes and plasma proteins. Then the reaction is controlled and terminated. So and finally the damaged tissue is repaired. That's normal sequence of events in every inflammation. But you understand that it sometimes goes wrong, sometimes it goes much more damageful, and doesn't reach some of these steps. Let's take a view of this. Inflammation may be of two types, might be acute and chronic. So, initial rapid response to infections and tissue damage is called acute inflammation. So it's appeared in a very short way. It might appear in minutes or hours, and it has a very short duration. Sometimes it might last for a few hours, and sometimes a few days. So everything which goes after this is chronic inflammation. A main characteristic are the exudation of fluid and plasma proteins, which is known as edema, and the emigration of leukocytes, predominantly neutrophils, also called polymorphonuclear leukocytes. You know them. So, in morphology, you can observe the acute inflammation by possession of large amount of leukocytes of neutrophils in this area, and I will show it in diagrams here in this book. When acute inflammation achieves its desired goal of eliminating the offenders, the reaction subsides and residual injury is repaired. But if initial response fails to clear the stimulus, the reaction progresses to a protracted type of inflammation, which is known as chronic inflammation. Chronic inflammation. Previously we discussed that chronic inflammation may follow acute inflammation or arise de novo. So some types of injuries followed with some types of chronic inflammation appeared after the acute inflammation. Sometimes nature of offending agent is prescribing the chronic progression of this disease. So like examples, for example, acute inflammation of kidneys, pyelonephritis. So it might continue if we don't treat it. If our body can't heal itself, this acute inflammation might progress into the chronic inflammation. That's how acute inflammation goes into chronic inflammation. But other type, for example, bacteria known as bacteria tuberculosis. So by nature of this bacteria, it doesn't have acute inflammation in this area. It doesn't provide the acute inflammation, but it provides the chronic inflammation, de novo. So anyway, so we have this type of inflammation. So chronic inflammation is longer duration and is associated with more tissue destruction, the presence of lymphocytes and macrophages, the proliferation of blood vessels, and fibrosis. So when you see that after the inflammation, in the histological review, you can find more lymphocytes and macrophages than neutrophils. So blood vessels are proliferated. So I mean, a large amount of blood vessels present in this area, and it is followed by fibrosis. So when fibrous tissue appeared around this site of inflammation, we can easily conclude that this was chronic inflammation. So that's typically a typical division. And of course, we have no border lines. So of course, we have gradiently transmission from acute inflammation to chronic inflammation. That, don't forget about this. That now we are talking about schablons, yes, so some types of abstractions, but in reality you will always see the sequence of these changes, and they don't go so today 1 second it is acute inflammation, and after the second it starts the chronic inflammation. No, it never goes this way. So we have a gradual transmission from acute inflammation to chronic inflammation. So let's talk a little bit about this diagram. So, causes of inflammation. So, microbes might enter into cells and tissues. And in connective tissue, in loose connective tissue, we used to find macrophages, dendritic cells, and mast cells. Yeah, and you remember from histology that their function is immunity. Somehow, so in histology, used to answer, so their function is immunity, and what's the difference between them? You don't care. But today you have to understand the difference between their response and what is similar, what is different in their responses. So microbes. So what happened to microbes? Microbes must be digested by macrophages. Mechanism of this digestion we'll discuss later, but main idea: macrophage finds these microbes, destroys them, and if these microbes are a little amount present in our body, so they destroy it, and without any consequences, it will be damaged. It will be destroyed, and we will forget about it. But in larger amounts, we need to macrophages start to destroy this protein, destroy these microbes, and present the antigen on its surface to teach immunity cells to kill this type of bacteria later. And mechanism of this we'll discuss later. Then we have dendritic cells. Dendritic cells are like very close by function to macrophages, so it has less function of phagocytosis, but more function of antigen presenting. So these dendritic cells are nominally present for antigen presenting. They digest bacteria, destroys it until small particles, and present their particles on the surface of its cell to teach our immunity cells to kill directly this type of bacteria. You see, functions of macrophages and dendritic cells are pretty similar, are quite similar, but macrophages are more aligned to kill bacteria, but dendritic cells are more aligned to teach immunity cells to kill this bacteria. Yeah, that's a difference. But in general, idea of the cells are similar, and actually derivation of these cells are similar. Might be remember blood formation topic in histology. They also explain that they are derived from the same lineage of cells, so macrophage family of cells. And we have mast cells. So it works absolutely different way. You remember that in blood we have basophils, and in connective tissues we can find mast cells, which are very close in function, close in appearance. Main point that mast cells, when they have a specific reactivity to this bacteria, when they already have the sensitivity to this bacteria, or might be some common type of irritation goes to mast cell. So inside the mast cell we have specific granules. Granules which are containing histamine, heparin, so heparan sulfate, and so on. We'll discuss later. And the main idea is that these mast cells get degranulized. So it's degranulized, and mediators which are produced by mast cells causing the inflammation. So, but anyway, and macrophages and dendritic cell and mast cells, they're producing some mediators, might be amines, some cytokines, and together they they call for immunity cells in this area. So if macrophages sometimes may handle it without calling the new cells, but dendritic cells and mast cells, they always in different patterns, but they always attract more and more leukocytes from the blood. So because most of our immunity is located inside our blood. And then mediators, they recruit new neutrophils. Neutrophils, by sequence of events we'll discuss later, neutrophils embed from the blood vessel into the connective tissue. And also monocytes, lymphocytes, they also get attracted to the area, and here starts the inflammation. Here is the main feature of inflammation. So and how it goes, we'll discuss a little later. So, and then when neutrophils enter into the site, neutrophils and monocytes enter into the site of ending agents presentation, they facilitate active phagocytosis, so present edema, so is additional case for penetration of neutrophils and monocytes into this. And then macrophages normally produce growth cytokines, growth factors to fibroblasts, smooth muscle cells, and then a healing process happened and repair happened after the inflammation. And then when eliminated tissues or microbes or any offending agent, so then repair happens. This general plan of the inflammation. So that's the first thing you need to understand. Okay, let's talk about features of acute and chronic inflammation. So acute inflammation, so onset of disease is fast in minutes or hours. It appears, and that's why patient will always say to you that when your disease starts, they can say even hour when they start to feel this pain. But in chronic inflammation, they can explain. So very gradually, in few days, I felt that some disease, some pain appeared, and then it increases day after day. That's chronic inflammation. Okay, we have in acute inflammation, in cellular infiltrate. In tissues, we mainly can find neutrophils. But in chronic inflammation, as I said before, it's monocytes, macrophages, and lymphocytes. So because we need a hard attack, hard impact of this of immunity, so higher level of immunity requires here, which is monocytes and lymphocytes. Okay, tissue injury. Tissue injury in acute inflammation, and fibrosis happened mild and self-limited. So then in acute inflammation, self-limited inflammation happened. But in tissue injury, it might be tissue injury in chronic inflammation might be severe and progressive. Severe and progressive. Then local and systemic signs. In acute inflammation, they are very prominent. So it will be fever, it will be pain acutely present. So that's manifestation is very high. But in chronic inflammation, we have less local and systemic signs. Less systemic signs. Okay, inflammation is induced by chemical mediators that are produced by host cells in response to injurious stimuli. So that we'll discuss in details which cell produces which chemical, but keep in mind that response in chemical releasing, some chemicals are released. When microbe enters the tissue or tissue is injured, the presence of the infection or damage is sensed by resident cells, including macrophages, dendritic cells, mast cells, and other cell types. And then these cells secrete molecules, then cytokines and other mediators, chemokines, and so mediators. Yes, so all total name of them are mediators. Induce they regulate the subsequent inflammatory response. Mediators produced from plasma proteins react to the microbes or to product of necrotic cells. Some actually necrotic cells, they also can be named as mediators. So some of these mediators promote the efflux of plasma and the recruitment of circulating leukocytes to the site where the offending agent is located. Mediators also activate recruited leukocytes, enhancing their ability to destroy and remove the offending agent. So this later in this lecture, so in next lecture, I guess we'll discuss the role of chemical mediators. Now we'll review the main steps in inflammatory reaction. So, external manifestation of inflammation, often called its cardinal signs. And this cardinal signs you have to remember once and forever. So please, it's color, rubor, tumor, dolor, and functional laser. So it is heat is a color. So it might be localized heat or fever. So it's one of sign of inflammation. It's manifestation of inflammation. Redness. So due to presence of blood vessels here. So when the blood vessels get diluted by mediators. So that's why in inflammatory area we always have more blood vessels. And in normally you remember from histology, so most of capillaries and arterioles, they are collapsed. They're collapsed, and inside they have very or collapsed or very little blood flow in these areas. But due to inflammation, all this potential is revealed, and that's why we see redness in this site. And actually it also promotes the heat in this area because more blood enters here, and that's why heat is produced in this area. Then swelling also termed as tumor. Swelling is a process so happened when plasma components released outside the cell, outside the blood vessel. So due to this, swelling happened. So more plasma entered into extracellular matrix, and it causes the tumor. Okay, and then pain. Pain happens because of some mediators. For example, we have which mediators? Bradykinin, serotonin released, and also it causes the formation of prostaglandins. Prostaglandin E2, for example, E1 and prostaglandin E2. So they are more. They provide the pain sensation. Later we'll discuss what is a pain, what's the cause of pain in details. And finally, loss of function. Loss of function happens due to damaging of due to all of this previously described features. So heat changes the metabolic activity of enzymes in these tissues. So swelling causes the disintegration of different components of this tissue. So redness also increase the blood intake here. That's why function of these tissues get changed. It not always decreasing, might be increasing functions happen this. Okay, and four of these signs are described even 2,000 years ago. So maybe you know this name. It's Celsus. Celsus, it's an ancient doctor, and he in his tractate De Medicina. But later fifth one, it's functional laser, was established by Rudolf Virchow, which is also so in the first lecture I said to Rudolf Virchow is the father of pathology actually, and father of modern pathology. He divided the pathology like different subject, and he started to learn the pathology like different subject. Okay, normally protective. In some situations, the inflammatory reactions become the cause of disease, and the damage it produces is its dominant feature. So don't forget that inflammation can cause injury to the cell. And as I said, in 99% of inflammations, it leads to normal effect. It leads to repair process. But in 1%, when inflammation gets too severe or over, how it's called, is overreacted inflammatory response causing the some damage features. So, for example, so we have inflammatory reaction to our own cells. It is known as autoimmune disorders. That's one thing. It's like rheumatoid arthritis, lupus erythematosus, rheumatic disorder, and hypersensitivity reactions like anaphylactic reactions. All of this causing the it is all subtypes of inflammation. And we have a lot of different examples here, which are shown here. So please read it. And later we'll discuss them too. But don't forget that every cell injury might cause the inflammation reaction. Okay, disorders caused by inflammatory reactions. So, for example, acute respiratory distress syndrome. You heard about it in coronavirus infection. Yes, that it's one of the most common type cause of death during this disorder. So it's caused by neutrophils. So how it happened? So how neutrophils damage tissues? So we'll discuss a little later. Then asthma. Asthma are caused by IgE antibodies, which are attached to basophils and produce too many pro-inflammatory agents, and also eosinophils are involved in this in the process of damaging here. Then glomerulonephritis. It's inflammation of glomerular apparatus of kidney, so it's associated with antibodies and complement. Also, neutrophils and monocytes are involved in glomerulonephritis. So it's autoimmune. Once again, it's autoimmune disorders. And we have septic shock. Septic shock, it is also might be heard about cytokine storm. What is cytokine storm? It's also one of the causes of death during the coronavirus. So not only coronavirus exists, but now it's very nowadays example. And chronic inflammation. So for example, in arthritis, they involve lymphocytes, macrophages, and might be antibodies. So in asthma, we have eosinophils and IgE antibodies, same as here. Even in chronic, so when it's acute, and we can treat it properly, and the reactivity is still present, so it's causes the inflammation. Atherosclerosis, they involve macrophages and lymphocytes, and pulmonary fibrosis, so macrophages and fibroblasts, they are involved in fibrosis. So let's talk about this. So inflammation is terminated when the offending agent is eliminated. So once again, what is offending agent? Microbes, virus, protozoa, fungi, or any other foreign body, might be damaged tissues, might be necrotized tissues, and might be our own cells, which are our immunity is charged to. For example, we have some immunity against some specific type of cell in our body, and until this type of cells are not eliminated, so then inflammation will be continued. So that's termination of this. And in termination, so we have different types of outcomes of inflammation. It will be in the third lecture, I guess. So which outcomes of inflammation we have? But for instance, we have to say that it might be scarring, formation of scar, connective tissue. Connective tissue just feels the defects which are made by this inflammation. Might be just tissue repair. So best way of healing it's repair. So total repair when all tissues became functionally similar as it was before the inflammation. Okay, later we'll discuss it. Then causes of inflammation. What causes the inflammation? Once again, infections, all the types of infections. We discussed it before. Tissue necrosis, when cells died and they activate the so it might be caused by ischemia, trauma, physical chemical injury, all the things we discussed before in previous set of lectures. Okay, then foreign bodies. Some foreign bodies, so might be splinters, dirt, sutures, they elicit inflammation by themselves or because they cause traumatic tissue injury or carry microbes. So that, but it's foreign bodies used to give the inflammation. That's why surgical intervention is shouldn't be always should be typical invasion to our body. So that's why a lot of doctors can say to you that it's better to avoid surgery because when we do surgery, of course we have foreign bodies. So first of all, sutures. Yeah, when we have sutures, they are collectors of. So when we suture something, when we tie something, so the cells which are present under these sutures, they died due to pressure. Okay, let's skip it so I know you know it. And immune reactions. So immune reactions, it's known as hypersensitivity. It causes the autoimmune diseases and different types of allergies, which we will discuss in the immunity diseases. Immunity diseases, like in chapter number 5, we'll discuss it once again. Then, but the main task of inflammation is recognize microbes and damage cells. So how they are recognized? So first of all, we have the first step in inflammatory response is the recognition of microbes and necrotic cells by cellular receptors and circulating proteins. Okay, let's talk about triggers which cause the recognition of microbes. Cellular receptors for microbes. So we have specialized receptors in our immunity cells which causes the inflammation. For example, phagocytes, dendritic cells. So as I shown you before, so here I'll try to show it again. So macrophages and dendritic cells, they possess specific receptors on the surface. They are known as toll-like receptors. Toll-like receptors, because for the founding member known as toll, a gene that was discovered in Drosophila, so it's called as toll. That's why we used to name them as toll. Toll-like receptors, they're located in plasma membranes and endosomes, so they're able to detect extracellular and ingested microbes. So other microbial sensors are present in the cytoplasm of cells. Toll-like receptors recognize motifs common to many microbes, often called pathogen-associated molecular patterns. So almost every bacteria possesses PAMPs, once again pathogen-associated molecular patterns, and toll-like receptors respond on it. And that's why macrophages, so once again, let's turn back to this diagram, that due to this toll-like receptors, macrophages identify the bacteria. They don't identify which type of bacteria is it, but they identify that bacteria is present here and they start to digest it. Same as in the dendritic cell. They also have toll-like receptors. They identify it and try to swallow it and cause all this sequence of events. Okay, because most of microbes possess these pumps. Then recognition of microbes by these receptors stimulates the production and expression of a number of secreted and membrane proteins. These proteins include cytokines that induce inflammation, antiviral cytokines, so you might be heard about them as their interferons, and cytokines and membrane proteins that promote lymphocyte activation and even more potent immune responses. So first of all, you see, okay, anyways, they ask for help. Yeah, when we digest something, we ask for help to find more cells which will help them in this injury. Then sensors of cell damage. All cells have cytosolic receptors that recognize molecules and are liberated as altered as a consequence of cell damage, and are hence appropriately called damage-associated molecular patterns. So these special DAMPs, for example, it includes uric acid, so which is happened when DNA has been damaged, ATP, which released from damaged mitochondria, then reduced intracellular potassium concentrations. So it also, as we discussed in cell injury, then when potassium level decreases due to membrane damage, Um, and DNA, DNA itself, when it's released into cytoplasm and not sequestered in nucleus, and it also is a signal to destroy the cell. It causes inflammation. Receptors activate a multi-protein cytosolic complex called as inflammasome, which induces the production of the cytokine interleukin-1. So please remember this interleukin. Interleukin-1 is the main, first interleukin which were found, and it's released by damaged cells. Interleukin-1 recruits leukocytes and thus induced inflammation. How it induced, we'll discuss later. Gain-of-function mutations in the cytosolic receptors are the cause of rare diseases known as autoinflammatory syndromes that are characterized by spontaneous inflammation. So, they are found in diseases like obesity-associated diabetes, in Alzheimer's disease. So, in relevant chapters, we'll discuss it. Okay, circulating proteins. So, which circulating proteins are responsible for recognition of microbes? So it's first of all it's complement system. We have complement system. We have a numerous amount of complement proteins, and we have these different reactions. We'll discuss it also in the third lecture. It reacts against microbes and produce mediators of inflammation. So it will be discussed, as I said, in the third lecture. A circulating protein called mannose-binding lectin recognizes microbial sugars and promotes ingestion of microbes and activation of the complement system. Other proteins called collectins also bind to microbes and promote their phagocytosis. So it's like used as marks of the on the surface of the bacteria, and it helps to macrophages to digest the cells. So summary. So actually, entire my lecture was about summary. Let's continue with the next chapter is acute inflammation. Acute inflammation has three major components. It's dilation of small vessels, leading to increase in blood flow. It causes the redness and swelling. Yeah. Then increased permeability of the microvasculature, enabling plasma proteins and leukocytes to leave the circulation. That's called the swelling. Yeah. And that's how cells of immunity reach the area which were damaged by bacteria or necrotized tissue or any other causes of inflammation. Then third one is emigration of leukocytes from the microcirculation, their accumulation the focus of injury, and their activation to eliminate the offending agent. How it goes, we'll discuss right now below. Reactions of blood vessels in acute inflammation. So how we have, which changes we have? So first of all, so the vascular reactions of acute inflammation consist of changes in the flow of blood and the permeability of vessels, both designed to maximize the movement of plasma proteins and leukocytes out of the circulation and into the site of infection or injury. So that's, you understand, yes, the main function here to increase the blood flow in this area. And then more and more plasma components and also more immunity cells might reach this site of inflammation. Okay, and escape of fluid from the blood is known as exudation. Exudation. So, and students used to confuse exudation and transudation. So keep in mind that exudation, it is a process when all plasma components are leaked outside. This is exudation, and sometimes even cellular components transport through the blood vessel. But transudation is another type. In transudation, only small molecular components leak outside. It is not related to inflammation, usually. Usually it's hardly related to this. It's because of it's happened due to increased blood flow in this area without inflammation, or might be caused by the congestion. So it will be also part of our topic, part of our next topics. So it is causes transudate. So you see, in inflammation we have exudation. Transsudation, we don't have inflammation. Transsudation is usually another pathology process happens. In chapter number 4, it's discussed. Then edema. Edema denotes an excess of fluid in the interstitial tissue or serous cavities. So when edema, it's excessive fluid. So we can find excessive fluid in areas we didn't used to see this excessive fluid. And we have a specific type of exudation. It's purulent exudation. Purulent exudation, we'll discuss it in morphologic patterns of inflammation. In purulent exudation, inflammatory exudate rich in leukocytes, usually neutrophils, and debris of dead cells, and in many cases microbes. So when it's inflammation associated with microbes infection, so we can find all these components: neutrophils, debris, and microbes. Neutrophils, debris, and microbes. Yes, I was right. Okay, then finally, changes in vascular flow and caliber. So, first of all, vasodilation is induced by the action of several mediators, notably histamine. I remind you, histamine is released from basophils and mast cells. So, and most obvious manifestation of inflammation is made by this histamine. And actually, in laboratory cases, we just promote the acute inflammation. So we, artificially model of inflammation is promoted by histamine injection. And it causes what? It causes the dilation of blood vessels. Dilation and increases the blood flow in this area. So all the blood vessels, they have this thickness, yeah, and vasodilation, so caused by histamine, cause them dilation of these blood vessels. And sometimes between endothelial cells we have gaps through which transsudation and also exudation is possible. So vasodilation is quickly followed by increased permeability of the microvasculature. That's what I was talking about. Increased permeability. First of all, vasodilation, so to increase blood flow. Secondary, increase permeability of the blood vessel, and it causes the exudation to the extravascular tissue. Okay, the loss of fluid and increased vessel diameter lead to slower blood flow, concentration of red cells in small vessels, and increased viscosity of the blood. These changes result in stasis of blood. It is known as sludge phenomenon. So that's why we can see erythema. So more erythrocytes are present there, and less blood and less water. So it's like filtration of blood, and erythrocytes and other cells are located inside, but fluid and proteins exudated outside. Let's talk about this. So here is shown the difference between exudate and transsudate. Yeah, in normal cases, so plasma proteins keep the water inside the blood vessel. And hydrostatic pressure and colloidosmotic pressure is in equilibrium. But in exudate, when proteins leak outside, so blood flow also streams toward following the protein exudation. So that's why loss of water goes in a case of exudation. But in transsudate, you see proteins are present here. It might be caused by low protein amounts, might be by increased hydrostatic pressure, but through the normal blood vessel, not inflamed blood vessel, this liquid goes outside. That's what I was talking about. Increased vascular permeability. Why it happens? In normal cases, neutrophils or leukocytes, they keep being inside the vessel lumen. And in tissues, you can never find neutrophils. Then, but in initiation inflammation induced by histamine or other mediators, blood vessels increased delayed, and gaps appeared as we noticed before, and neutrophils and proteins of plasma, they released into the tissues. and this happened in few minutes. It's quite normal reaction, but sometimes in severe cases we have endothelial injury. So when caused by burns, some microbial toxins, and it appeared very rapid, maybe long-lived, so hours to days. So when actually entire blood vessel is damaged and exudation happens and neutrophils entered in the tissues too. Okay. Okay, responses of lymphatic vessels and lymph nodes. So they have. So you remember that connective tissue. So let me show to you. You see, connective tissue in which present macrophages, dendritic cells, mast cells, is actually is initiation of our lymphatic vessels. So it's you remember lymphatic vessels are blind end vessels which transport the material in the from the connective tissue toward the central part of toward the central circulation. And before it influx into the central circulation, it has checkpoints, and they're known as lymph nodules, lymph nodes, and other types of lymphatic tissues. So let's talk about this again. And in possession of bacteria in these lymphatic vessels and in lymph nodes causing the lymphangitis, inflammation of lymphatic vessels, and lymphadenitis, inflammation of lymph nodes. So it might be reactive or inflammatory lymphadenitis. Okay, so this will be discussed in chapter 12. Leukocyte recruitment to the site of inflammation. So that's main point, is the last point we'll discuss in this lecture, and one of the most important and tough points to discuss. So first of all, you see leukocytes are circulating in the blood, but we have to stop them and attract them into the site of inflammation. So how to do this? So let's talk about this. Leukocyte adhesion to endothelium. When blood flows from capillaries into postcapillary venules, circulating cells are swept by laminar flow against the vessel wall. Red cells, being smaller, tend to move faster than the larger white cells. As a result, red cells are confined to the central axial column, and leukocytes are pushed out towards the wall of the vessel, but the flow prevents the cells from attaching to the endothelium. So, but you remember, but when we have inflammation, so blood flow slows in our inflammation due to possession of stasis. So when the vessels are dilated, so blood flow slows down, and neutrophils are able to penetrate through the cell wall. So and hemodynamic condition change. For example, wall shear stress decreases, and more white cells assume a peripheral position along the endothelial surface. And this process is known as margination. This is the first process. It's margination. So when the neutrophils appear peripherally in the blood flow. By moving close to the vessel wall, leukocytes are able to detect and react to changes in the endothelium, which changes we'll discuss right now. If the endothelial cells are activated by cytokines and other mediators produced locally, they express adhesion molecules to which the leukocytes attach loosely. So let's talk about this. But yeah, let's talk about this. Okay, we have selectins. What are selectins? Selectins are receptors expressed on leukocytes and endothelium that contain an extracellular domain that binds sugar. Hence the lectin part of the name. So that's due to this. Three members of this family. We have E-selectin, P-selectin, and L-selectin. And if E-selectin and P-selectin they are present in endothelial cells, L-selectin is present on the surface of most leukocytes. By nature they are similar, by function they are a little different. So I will show you the difference in these functions. Endothelial selectins are typically expressed at low levels or not at all in an activated endothelium. So when endothelium is not activated, selectins are not expressed. They're naked. One point, this selectins expression is correlated with activation of neutrophils, attraction of neutrophils in this area. And if endothelial cells are not attracting this, no inflammation is present. So why they should produce these selectins on the surface? And that's why they are expressed only in site of inflammation. That's why only sites of inflammation are correlated with inflammation itself. Okay. Unactivated endothelial cells, P-selectin is found primarily in intracellular Weibel palette bodies. So endothelial cells are ready for the expression of these selectins, but they're silencing in non-inflammatory causes. But E-selectin and the ligand for L-selectin. So you see, E-selectin is expressed on endothelial cells, and ligand for L-selectin, so means the site where L-selectin of leukocytes get attached, they are expressed on the endothelium only after stimulation by interleukin-1. I remind you, interleukin-1, it is produced by necrotized cells and also by tumor necrosis factor. Please remember this abbreviation TNF. It's tumor necrosis factor. These cytokines that are produced by tissue macrophages, dendritic cells, mast cells, and endothelial cells themselves following encounters with microbes and dead tissues. So later we'll discuss it. Leukocytes express L-selectin. You remember, but on endothelial we have L-selectin. So once again, they possess L-selectin ligand. So where is it? So somewhere here. Somewhere here was L-selectin. Okay, ligand for L-selectin. So it's produced in endothelial cells. And by the way, we have ligands and we have on the leukocytes we have L-selectins. They express on the surface at the tips of their microvilli and also express ligands for E and P selectins. And you see the structure. So endothelium produce 2 selectins and 1 ligand to selectin. And leukocytes express 1 selectin to this ligand and 2 ligands to another selectins. And you see the situation that leukocytes possess 2 ligands and 1 selectin, yeah, like this. Like this way. But it possesses 1 ligand and 2 selectins, and they are joined together. But these selectins, so let me show it this way. So on this diagram it's visible. So we have selectins, P-selectin and E-selectin expressed on the endothelial cells, and we have L-selectin on the surface of leukocyte, which are not shown here. And then gradually leukocyte join to this, and you remember it's marginated. Leukocyte start to gradually attach to these selectins, and ligand, 2 ligands of selectins by the selectin L-selectin here, and that's why they attach to one selectin or selectin ligand and rolling goes. So and slowing down of transmission. So blood flow is still present. Blood flow detached from this, but it sticks 1, 2, 3, 4 times and gradually slows down. That's a function of selectins, not integration, but slowing down of neutrophils. That's the role of selectins. Once again, P-selectin and E-selectin expressed on the endothelial cells due to activation of macrophages, which produce TNF and interleukin-1. First of all, macrophages might be damaged tissues or might be endothelial cells itself when they're damaged by bacteria, and P-selectin and E-selectin transported. And also under the influence of same cytokines produced L-selectin ligand, and under the influence of same cytokines on the surface of leukocytes, they produced ligands for P-selectin and E-selectin, which helps us to stick to these selectins, and due to this, neutrophils is stopped. What happens after all? So let's discuss it here. So it was not fine adhesion. Yeah, so it was just loose adhesion to the surface of endothelial cells. The selectin and ligand selectin attachment. But we have also firm adhesion of leukocytes to endothelium, and is mediated by family of leukocyte surface proteins called integrins. Integrins are transmembrane 2-chain glycoproteins that mediate the adhesion of leukocytes to endothelium and of various cells of the extracellular matrix. They are normally expressed on leukocyte plasma membranes in a low affinity form and do not adhere to their specific ligands until the leukocytes are activated by chemokines. So chemokines are chemoattractant cytokines that are secreted by many cells at sites of inflammation by to endothelial cell proteoglycans and are displayed at high concentration on the endothelial surface. You see, in one hand, on leukocytes we have integrins. In other hand, on the surface of endothelial cells, we have intercellular adhesion molecule 1, ICAM. It binds to integrins leukocytes. It binds to integrins leukocyte function associated antigen LFA1. And also attached to macrophage 1. So MAC1, 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 and vascular cells adhesion molecule VCAM. So in easy words, so on the surface of endothelial cells, we have specific ligands for this. They are not selectins; they are specific ligands for integrins. Its integrin ligand is ICAM, as I noticed before. And what happens? So, I said before that integrins on the leukocytes, they're present in low affinity state. They can't attach to the integrin ligand. They're just present on the surface of leukocytes. But when some chemokines attracted, so some chemokines which are produced by macrophages and so on, these integrins start to become high affinity. So they are more adjustable to these integrin ligands. And when these chemokines activize this integrin, and they get attached to this integrin ligands, ICAM1. And now, finally, neutrophil stops on this point. What happened next? So, yeah, here. Then leukocyte migrates through the endothelium. That should be noted. So later we need to transport this leukocyte through the cell, through the endothelium, and how it happened. Let's discuss now. After being arrested on the endothelial surface, leukocytes migrate through the vessel wall primarily by squeezing between cells at intercellular junctions. This extravasation of leukocytes, called transmigration, occurs mainly in postcapillary venules, the site at which there is a maximal retraction of endothelial cells. Further movement of leukocytes is driven by chemokines produced in extravascular tissues, which stimulate leukocytes to travel along a chemical gradient. So it's described shortly before. In addition, platelet endothelial cell adhesion molecule PKM1, so also known CD31, an adhesion molecule of the immunoglobulin superfamily expressed on leukocytes and endothelial cells mediates the binding events needed for leukocytes to traverse the endothelium. After traversing the endothelium, leukocytes pierce the basement membrane, probably by secreting collagenases, and they enter the extravascular tissue. Typically, the vessel wall is not injured during leukocyte transmigration. So take a look here. Actually, these neutrophils, so by activized by PICA, yeah, activized, also activation of these integrins causing the activity of these neutrophils, and they start to go, start to penetrate by the process known as chemoattractant, chemi, um, chemoattractant molecules, so chemokines, they attract these neutrophils to this area. And by this chemotaxis, neutrophils, without injury of cells, they just penetrate through the cell membrane, through the basement membrane, by collagenases. They produce specific enzyme which destroys this basement membrane, and cells are able to push through this point. Yeah, we have PCAM as additional, CD31 is an additional event, so which assists in this, but it's not main event in passing of neutrophils in this area. And then finally, and here in extracellular matrix outside the blood vessel, these neutrophils finally can find microbes and digest them. Okay, you used to, on this point, you used to say to me that it's enough, it's too tough, and we need to make interruption, and I will do with you. So let's read this lecture again, observe it again, read the book, and you might read not only this book, you will have another books to observe it, and I hope you will understand this information point in on very high level. So if you reach this part of lecture, so I ask you to say to me in practical class, say to me word stapler. Say to me word stapler in practical class, and I will give you 1 point more than to others. Okay, by this you approve that you watch the lecture until the end. Word stapler. Thank you. Goodbye.